Okay, so now we have our review. Now's the time to ask me any epidemiologic questions you have. I will try to answer to the best of my ability.
The answer is C.
Or one of the answers probably going to be C. I should make a test where I actually have no C answers. That would really throw you guys off. Or then the next one will be all C. And then no, I when I went through pharmacy school, I was always my scariest moment. I'm like, I have like 5 D's in a row. This can't be right. Talking myself out of several questions. I should probably put it on the microphone. Anywho, okay, so no questions right off the bat. All right, we're done. I'll see you guys next. No.
This is random, but with the decision-making charts, how are we different than a computer?
How are you different than a computer?
Like, couldn't we just plug this into a computer and it make these decisions for our patients and make it more accurately without our bias?
That's the secret. In 10 years, you're actually not going to have a job. So no.
That's what Watson is.
No, because obviously you have to make individual decisions based on your patients. Like, it's not easy because and again, you have to balance everything on the fact that one, like, what's your patient going to be on board for? What can they afford? What are their religious values? What are all these different decisions that go into how you treat that patient, right? It's far too complicated for a system to just look at just a percentage and say, like, okay, well, you have the highest likelihood of not dying doing this. This is the best option for you to do it. Because that's not good medicine at that point, right? So you have to consider the patient as a holistic kind of snowflake and make decisions based on that sort of. You guys will probably have jobs. Pharmacists maybe not, which is probably why I went academic, but at least retail pharmacists, they might be in trouble. But yeah, so anywho, what other questions can I answer for you? You guys are all experts, I like it. Okay, so I have a few questions which you guys should be able to go through pretty easy. So we're going to review this. So you guys remember this chart? Yeah, so this was the cases of AIDS that were occurring between 1981 through 1992. So if I were to ask you, say we started off this study in 1981, we carried it out through 1992, so we're going prospectively. How would you calculate the incidence of new cases of AIDS? What part of the graph would be new incidence? Just the white? Just the not white?
On the left, the y-axis.
So the whole y-axis? Right, so in this case, if we're looking at new incident cases, so in this case, it does not matter whether they died or lived, right? Because right here we know that basically the purple parts of the bar are going to be those patients that were known dead at the end of the study period, right? So in this case, if you're looking at actual incidence of AIDS that was diagnosed, this would be the entire height of the bars. In this case, it would be the whole 253,000 that we're looking at for this whole time period, right? So it'd be new incidence of it. Now, for instance, if I was saying I was at the end of 1992, say it's the January 1, 1993, and I said, what is the prevalence of AIDS in this patient population? Then what would you say?
That's the white line.
Just the white parts, right? Because those are going to be the patients that are still alive and still prevalent, right? The people that died off, they are not going to be included in that analysis anymore. So keep in mind the differences between incidence, prevalence, and how you can look at those based on whether you're looking retrospectively, prospectively, where it happens to be. So if I did say just a cross-sectional slice and say I just surveyed everyone in the U.S. today to figure out what the prevalence of AIDS was, I guess I gave away the answer. That would be prevalence, right? So if I just did a cross-section asking you, like, who has this condition, that's prevalence, right? Incidence is going to be new cases that occur as I move forward in time. Okay. So the Beans model, if you guys remember this, is a useful paradigm for, and then don't look forward to the answer, for allocating public health resources. You guys think yes or no? Okay, maybe not that one. Assessing the impact of herd immunity. That's what that is. Okay, not hearing any yeses yet. Determining the role of social policy on public health. Nothing. Okay. Establishing the importance of social contacts. How about evaluating etiological factors in disease? Okay, so maybe a few people looked ahead and saw the yes. That's probably the answer. Yes. So that is going to be evaluating those etiologic factors. So again, remembering what each of those factors are being. So like looking at biological or behavioral factors that are influencing epidemiologic. So looking at cigarette smoking or looking at sedentary lifestyle, all those different things. going through that and remembering which of those different factors that plays into. So genetic factors, or the environmental factors, whatever happens to be, at least be familiar with the different components of that acronym and how that can play a role in the etiology of disease, right? So you may ask a question on a test where it might be something like having a prostate cancer screening would be what type of, I guess I'm not really getting an example. So maybe I'll say something like, cigarette smoking, and in cases of new lung cancer would be what type of factor. And so going through the different beings one, so what type of factor do you think that would be? Yeah, it's behavioral, right? So you'd say, okay, that's a behavioral factor. So I'll maybe list out a few of the different components of the Bing's model, and then you kind of identify which one that plays a role in. So, for instance, I would say, presence of the BRCA2 gene in breast cancer. You'd say it's probably more of a genetic factor, right? So just being able to identify those is good. Okay. So this is the number of new cases over a defined study period divided by the mid-period population at risk. So it's a rate, right? Because we were looking at what? So looking at that midpoint population, right? Because if I was using the beginning population, that'd be what? That'd be risk. If I use the midpoint population, it's rate at that point. And so if I'm looking at new number of cases as I go forward, what does that be? Yeah, so it'd be your incidence rate. 100%. So again, incidence rate is going to be the number of new cases over a defined study period divided by that mid-period population at risk, okay? So why do I use the mid-period population? Why is that different than using the beginning?
People dying. Is it changing?
Yeah, so you're looking at the population who's at risk over a period of time, right? So for instance, if you're looking at death, if you have something that occurs where everyone dies in the very beginning, that would die for that year, your mid-period population is going to be higher or lower? Should be lower, so that would mean that your force of mortality in that case is going to be higher because that denominator is smaller at that point, right? Because your midpoint denominator, or your midpoint population is that denominator there. So as that gets smaller, that force of mortality, the force of that outcome for that rate gets higher. As opposed to if I had someone who all the people died at the end of the year, then that would have a slower force of mortality or lower force of mortality because I have a higher denominator in that case. Because again, basically that mid-period population is just an average of the number of people who are at risk during that time period, right? And so if I were to carry on, say, a study looking at death over 1 year versus 5 years, what would that do to the rate if I were to look at it over 5 years? It should go up, right? Why? Yeah, your denominator would be lower because I'm looking at the same number of people over a longer period of time, so that midpoint population is going to be even smaller, right? And so again, you can look at that risk of patients over time if you were to, again, use that natural log equation and all of that, which I'm not going to get too in-depth on the testing purposes, but just be aware of why we use incidence rate, why it's important that we use that mid-period population, and how that can influence things depending on that force of mortality. Okay. This is the observed total deaths in a population divided by the expected deaths in that population multiplied by 100. What that definition might be. This would be an example of a standardized mortality ratio. So again, definitions will be big on this test, so be aware of the different definitions that are there. So again, the standardized mortality ratio is being derived from those indirect methods, right? So this is a way that we can standardize mortality ratios in order to have a better way to compare apples and oranges, or if you're looking at, say, different countries and their death rates and things like that. So that observed number of deaths in the population is being divided by the expected number of deaths in the population, and you multiply that by 100, so that way you get rid of the fraction and you just have basically a percentage there you're listing. Okay, that makes sense? Okay, so go back and review your definitions. Let's see, this is the proportion of individuals with a given condition who die of the condition. So it's a proportion, so it's probably a ratio, right? And then we're looking at people who die. Ooh, sounds good. So case fatality ratio is the actual definition there. Very close. So again, you can kind of reason some of this stuff out just by looking at the question. But again, although the case fatality ratio is used to describe deaths attributable to specific infectious diseases, you can use it to describe it to deaths in lots of different reasons, lots of different conditions. So the measure requires that the number of affected individuals and the number of deaths attributable to that condition be known in order to calculate this, right? Okay. How about the number of live births divided by the mid-period population?
That would be the birth rate.
Okay. Any particular type of birth rate? It's not fancy. It's pretty crude. It's a crude birth rate, right? So again, this is going to be calculated as the number of live births divided by that mid-period population. It's not technically a valid rate because everyone in the denominator can truly be said to be at risk for the numerator event, right? So really only women of childbearing age are at risk for bearing children. So keep in mind the population that you're actually looking at and if they're truly going to be at risk or not, if that rate's going to be valid. Bless you. Okay, so this provides a death rate within a defined age range. Okay. This would be an age-specific death rate, right? So this is the way that we could utilize the different proportions of the ages in a population and be able to make those kind of comparisons. So again, age is going to be one of the strongest predictors of mortality, obviously. So death rates that do not reflect the experience of a particular age group are difficult to interpret. So again, this is like we're comparing, say, Ecuador, I think, to Sweden or whichever South American country it happened to be. I apologize, I don't remember. But Sweden obviously had an older population, so they were more likely to have a higher mortality rate, even though really their life expectancy was higher than in a kind of a younger population like Ecuador. So just keep that in mind. This helps us to make those comparisons a little bit better when you do age-specific death rates. Okay, so let's say, a little case-based question. So let's say we had a politician throwing a luncheon fundraiser, serving up various types of seafood, including a very delicious salmon mousse. Within 24 hours, 11 of the 17 diners experienced abdominal pain, vomiting, and diarrhea. Of the 11 symptomatic guests, 4 had fever, 7 did not. 5 had an elevated white blood cell count, 6 did not. 6 ate the shrimp bisque, 5 did not. 9 ate salmon, 2 did not. You can refer back to the slide when we go over some of the questions. And 1 goes on to have surgery for acute cholecystitis resulting from an impacted stone in the common bile duct. So of the 11 symptomatic guests, 10 recover within 3 days, with the exception of the person who underwent surgery. It took a little bit longer for him since he underwent surgery. So now let's ask some questions about this. This phenomenon would be described as a coincidence until proven otherwise. You don't think so? No? Too odd that all these people are having the same thing at the same time, right? How about a disease outbreak? You don't think so? What would make it an outbreak? If it was bigger? It happened somewhere else too? So maybe if it had like a couple of different places had it at the same time, that would be an outbreak? What does the term outbreak mean?
I think just more than the expected number.
Okay, good. So if you were to have a luncheon, so say I served you guys all lunch and had 30 of you come down with these same symptoms, would that be more than expected?
Hopefully.
Yeah, probably, unless I just don't like you guys. And yeah, we're not going to look at sabotage here or anything. So okay, so let's camp out on that one for a minute. But how about is it attributable to bacterial infection?
Not yet.
Yeah, too soon to know. We don't really know that yet. It is not an outbreak because the usual pattern of disease is unknown.
No. We know that you should go to lunch and not get sick.
Yes, true. Unless you go to like a Chinese buffet and you just don't get that 4th plate, but you do it anyway. But just kidding. Just kidding. The self-loathing usually sets in after 3 plates. So. Okay, and then should be investigated by the CDC. You don't think so? What would make you want to have the CDC and start investigating it? Okay, so say like multiple states were being affected, that would certainly be one.
Reportable disease.
Yeah, maybe certain reportable diseases they might get involved with. So if in the case of smallpox, like chances are CDC is going to come running, right? So good. Okay, so what do you think the right answer is going to be here? B, right? Absolutely. So B is going to be the correct answer here because again, no one should expect to get super sick after they go and eat lunch, and because there's a higher rate than what you would expect, that would be considered the outbreak here. And CDC would not usually investigate such a small kind of localized outbreak unless they needed to for some reason, or if they if it was interstate, or if they had a request from, say, a public health official. So this is actually kind of interesting. This is one of the things that you may not think of poison centers doing, but they are a very valuable source of epidemiologic data for tracking food poisoning. And so we actually will have patients who will call the poison center saying, hey, I think I have food poisoning, blah, blah, blah. We actually collect all the data on where they ate at, what they ate, what time it happened, what symptoms are happening. We collect all this information into a standardized form, and then we actually ship that off to the Department of Health. So that way, if you can actually track this stuff geographically, because we can see what zip code people were calling from. And so even though you may have people who, say, called the Miami Poison Center or the Tampa Poison Center or Jacksonville, we can actually localize where all the cases are happening and potentially link it back to a specific location, right? Or if you have, say, like contaminated produce from, say, Walmart, like there's listeria on the asparagus or something, you can start to track that stuff back down through the Department of Health, since we're sending all this data in real time. So it's kind of interesting how you can do that, start to investigate this patterns pretty quickly. So everyone clear on how that one works? Okay. All right, so what would you say the attack rate in this case is? So we had 17 diners. I think it's E. It's 11. That's why do you think E?
Number of people out of number of people exposed.
Yeah, so number of people exposed versus the number of people who became symptomatic, right? So in this case, it'd be 11 out of 17, right? So it's not particular on any set of symptoms, but it's those that became symptomatic that are going to match the next thing we'll talk about here. So again, attack rate, proportion of persons who became ill. As the investigation of the outbreak begins, exposure is likely to be defined as participation at the luncheon, right? So again, if they did not eat at the luncheon and they just had come up with a GI upset, chances are they're not going to be included with this group, right? So as we proceed, we're going to see that, if we can look for one particular exposure, if we can see that, okay, they all ate this one particular food, or at least the most higher proportion of people ate the same type of food, that can start to be implicated, and you can start to do a little bit more focused investigation. But in this case, since we don't know particularly what the actual exposure was, we can just say 11 out of 17 for that whole group. So an early priority investigating the phenomena would be to close the kitchen temporarily, so no one else can eat here. You think so?
Costs a lot of money.
Costs a lot of money. I guess it depends on where you're at. Yeah, could be lots of money. Define a case. I think I see one head nodding. Okay, we'll come back to that. Perform a case control study.
Wow.
Probably a little premature to do a case control study. How about performing stool test? Always do stool test. You guys ever watch Scrubs? There's they have a song called "Check the Poo." Usually can diagnose most everything with that. And then submit food samples to the laboratory. So you gotta sample everything. So probably the most prudent thing to do, and probably the easiest thing to do right off the bat, is make a case, right? Define who it is specifically you'd like to investigate further, right? So in this case, we want to define a case, because this is going to help us to establish either a diagnosis or a case definition early on to lead our investigation towards one way or the other. So if you can say, okay, let's look at patients who all had nausea, vomiting, diarrhea, all had a high white count, whatever it happens to be, make that our case, and then you can start to weed out people from that, right? So out of that initial 17, you say, okay, well, 6 people were not symptomatic, so let's just weed them out and find out what a common source of exposure was for those that did become symptomatic. So again, usually you'll find lab tests, case control studies usually going to be performed later on in an investigation, but defining that case is going to be the first thing you want to do here. Okay. The best case definition for the guest disease would be abdominal pain, vomiting, diarrhea within 24 hours of the state luncheon, acute viral gastroenteritis, staphylococcal food poisoning, onset of abdominal pain and fever after the state luncheon, or vomiting, diarrhea, and elevated white blood cell count. I think A. Why A? Okay. Right, so it establishes a temporal relationship, and then it also is looking at particular symptoms that all of those symptomatic individuals had, right? Why wouldn't E be good, besides the time frame thing? Exactly. Not everyone had a high white count, so that would be one thing that would not be included in your definition. We want to look at all the people who are symptomatic and what was the common links between them. So symptoms and then the time frame here. So A would be the correct case definition in this case. So again, while this may not provide perfect sensitivity and specificity, because we probably saw that the guy who went for cholecystitis probably had very similar symptoms, doesn't necessarily mean that he could be included as one of those cases, right? He could be a false positive, but he obviously had another compelling reason to have gastrointestinal issues. So again, keep in mind that you won't have perfect sensitivity and specificity, but it's a good starting point. And then later on, you can start to say, you can kind of broaden out your case definition to start to weed out the false positives. So you can say, okay, well, all these people ended up eating that salmon mousse. Let's just include that in our definition. So you had to eat the salmon mousse, have these symptoms within 24 hours, right? So that way you can get a better idea of who it actually affected. Okay. Suspecting that the disease is a result of common source exposure involving contaminated food, the investigators attempt to determine which food is responsible. Their initial task is to analyze the food specimens in the laboratory. What do you think? Okay, not a strong opinion on that. Close the kitchen. No. How about examine the food preparers? See if they have any health code violations in their past. Maybe that was involved. Interview the symptomatic guests to find out what they ate. Okay.
That was provided in the STEM.
Let's say the investigators didn't know that yet. The people at the restaurant did. And then perform a case control study. Again, that's probably something that happens a little bit later. Yeah, so you want to find out, interview the symptomatic guests and find out what they ate, because you want to find out what the common source was. So if you can say, like, well, no one here ate the shrimp, so they're probably not involved, or yes, they all ate the salmon, whatever happens to be. So that's the first thing to do, and then that way you don't have to test all the food. You can just test specific things that they all had in common. Good. Okay, let's see. A screening program analog to the late look bias would be which of the following? So length bias, because cases lasting longer are more apt to be detected. Recall bias, because only severe illness is recalled. Selection bias, because the program selects out asymptomatic illness. Selection bias, because the program selects out severe cases. Or spectrum bias, because the patients are clustered on one end of the disease spectrum. So which one do you think this late look bias is similar to? I think B. Okay, so let's say, what do you think the late look bias is? Think it's A? Some probably already looked. Okay, so this is going to be A. Let's look at the reason why we were going to call this analogous to the length bias. So essentially, when you're looking at length bias, the tendency is to detect preferentially long-lasting cases, right? So people who got really sick really fast and died or recovered are not typically going to be captured there. So that's that late look bias you're talking about there, which is very similar to the length bias. So also is going to capture those subclinical disease cases and things like that. So looking at other issues, so certainly selection bias was not being analogous to this. This would be kind of a case of, especially if people are deciding which kind of arm of a study they want to go into themselves, that can be a form of selection bias. And none of those other ones really kind of apply back to what we're talking about there. So just keep in mind that screening programs for long periods of time have a hard time capturing those severe cases that are very rapid. Okay. Any questions on that? Okay, so let's see. We're looking at a study that's conducted to determine the effects of, and I did not come up with this one, which I thought was kind of interesting, but drinking Mountain Dew on a teenager's willingness to bungee jump from frightful heights. Don't know if there's any actual link there, but let's see. Maybe like Mountain Dew drinking and Dorito eating, possibly, but who knows. But let's say we're looking at 500 teenagers. They're assembled on the basis of their bungee jumping status. So whether they bungee jumped or not, there's 250 in each group. Of the 250 jumpers, 150 reported drinking the Dew, and the 250 non-jumpers, 50 were drinking a Mountain Dew. Most of the non-jumpers reported a preference for warm milk. I truly did not come up with this example. I left it in because it was kind of ridiculous. Okay, so which of the following do you think would be true? Jumpers and non-jumpers should be matched based on their beverage consumption. You don't think so? Why not? Know what you're testing for? So what type of study are we doing here? So do we know the outcome already? Right? Because what's our outcome?
Jumping.
Yeah, do they jump or do they not jump, right? So have our outcome, and then what are we investigating?
Beverage.
whether they do the do, right? So you have to figure out what their risk is, right? So you have to figure out what the risk factor was that was associated with that. So if anything, this would be very similar to like a case control study, right? Your cases are the jumpers, non-cases are the people, the controls are going to be the people who did not jump, right, in this situation. So, so we'll come back to that one. The absolute and relative risk of bungee jumping can be determined from the study. Why not? Because we're looking retrospectively, we can't actually come up with real risk because, again, we found cases and controls for them. We didn't actually have the whole population of a sample to look at. This is a cohort study. Why not?
Does it have to be like an actual brain? Or, oh no, you have to follow that too.
Yeah, so you need to follow, typically you're going to follow them forward. So if you were to arrange them based on whether they drink Mountain Dew or not, that would be the risk factor, and then you look for the outcome, right? So if I look to see what the risk factor is first, or their exposure, then I saw what the outcome was, that would be a cohort study. Because I'm looking at their outcome first, categorizing them based on that, and then looking to see what they drank, that's not going to be a cohort study. So the study can be used to calculate an odds ratio. Yep, you could do that. And then anticipated outcomes can be assessed in the study. No, right? So in this case, when you're doing a case control study like this, you cannot assess for different outcomes, like because you picked your patients based on the outcome there, right? So if you start to find new outcomes in that group, that's not really valid. On the other hand, though, you can find several risk factors, though, that could be associated with whether you jump or not jump. And on the other hand, if I did a cohort study, I would have to set my risk factors beforehand or my exposures, and then I could look at several outcomes, right? So keep in mind how what you're looking at a priori and what you cannot change based on that, right? So that's how you're categorizing your patients. Good. The jumpers and non-jumpers would not be matched on beverage consumption because that's what we're actually investigating. That's why we're trying to figure out whether they were drinking Mountain Dew or not. I think that kind of goes through all the details there. What's this idea of overmatching? What do you think that is? What does overmatching mean if you're doing a case control? You're matching too much? Good, so I overmatched. I overmet my matched. And so what does that mean, though? So if I pick my cases and controls and I make them too similar, so say there were some other factors here that influence whether or not they were jumping, like say living in their parents' basement or say playing WoW or whatever it happens to be. If I overmatch them and make them too similar, then I might not actually find any actual difference there, right? Because those people just may be so similar that they're going to have similar rates of drinking Mountain Dew. So based on that, if I overmatch, I might not be able to find a difference that's there. Okay, but here, you want to match on kind of obvious things like, maybe say gender, maybe say on age, whatever happens to be. But overmatching can lead to a lack of power to detect a difference. Okay. All right. So the odds ratio calculated from the study would give the odds of drinking among jumpers to drinking among non-jumpers. So a nod and then a. Okay, we'll come back to that. Drinking among non-jumpers to drinking among jumpers. Keep looking. Drinking Mountain Dew to jumping. It's kind of a poorly worded one. Okay, so we'll just kind of continue. So if you wanted to calculate the odds ratio, what would you say is going to be the odds you're looking at? So you're looking at jumpers, and what was the odds that they were drinking Mountain Dew, right? So you're seeing what the outcome was. You're saying the jumpers, and then what was the likelihood that they were drinking Mountain Dew. So this case would be A. So drinking among the jumpers to drinking among the non-jumpers. So you can see what the proportion of the odds were of those people drinking Mountain Dew versus those that were not. Okay. So again, the odds ratio for this case control study is the odds of the exposure in cases relative to the controls. So that's why we're doing the odds ratio. So, and then the exposure in this study is going to be drinking, specifically drinking the Mountain Dew. And then here are the cases of those who bungee jump, whereas controls are those who do not. So the odds of drinking Mountain Dew among cases relative to the controls is the outcome of interest. So again, as noted, the odds ratio here is essentially the measure of risk of having the risk factor. It's an important kind of concept to remember is that the odds ratio, when you're doing these case control studies, is the risk of having the risk factor.
This is a real study?
No, this is just, I hope not. That would be.
Can be.
Did you find the actual study?
It's an example that comes up in textbooks a lot.
Oh.
Well,
I do not know. I mean, it's a good illustration of the point there, and I guess that's an easy exposure to list. I mean, you could have put anything there. You could have put, I don't know, having a tattoo in skydiving or whatever happens to be. So, yeah. All right. So the results of the study indicate that bungee jumping and beverage choice are going to be associated. Bungee jumping and beverage choice are causally related. I say no. Why not? So I can't do causation. Why is that? What am I missing here? So I probably want to do, this could be an experimental study, right? So essentially what you're looking at is for causal relationships, what do you need to have? So time is a factor, right? So you need to have a temporal relationship. So I need to see that drinking Mountain Dew caused them to go bungee jumping, right? That would be a causal relationship. So because of that, we can't really show that because we can't determine that they were drinking Mountain Dew before they went bungee jumping. Perhaps they bungee jumped and then they wanted to have a refreshing dew to celebrate, whatever it happens to be. We can't prove that that was the course of events, right? Again, too much mileage out of this Mountain Dew subject. Anywho, so you can't say there's a causal relationship there. How about bungee jumping influences a person's choice of beverage? Yeah, probably can't say that necessarily. How about the choice of beverage influences a person's tendency to bungee jump? Maybe not, no. And how about there's no association between warm milk and bungee jumping? Maybe that's a real takeaway, right? So again, we're looking at the association between our outcome and what our risk factor is, right? So it doesn't really matter that they're drinking warm milk in the non-jumpers. That's not the exposure that we're looking at. So we're really looking at bungee jumping and beverage choice being associated, but we can't determine any kind of causal relationship between those two because we don't have any temporal relationship. We just don't have the study designed to show that. So again, if we were to do, say, a study beforehand, or if we were to do a prospective study where I gave people Mountain Dew versus no Mountain Dew and then saw which ones bungee jump afterwards, then I could potentially say there's more of either a risk factor or some sort of causal relationship there. But again, it's not a necessary cause. It's not a sufficient cause. What's the difference between a necessary and a sufficient cause? So necessary cause, what was the example we used? Well, sufficient cause. Yeah, TB was the example there, right? So it's necessary.
You have to have seen the TB before you can get, you have to have that bacteria before you get TB.
Right, so you have to have the bacteria in order to get TB, but if I have the bacteria, do I always get TB?
No.
Not necessarily, right? I could have a latent infection that never really manifests, right? So that would be a necessary cause. So they have to have the thing there, but it doesn't mean the disease is always going to happen. With a sufficient cause, though, what was a good example of that? So that's something that if it's there, you're always going to manifest the disease, right? So we mentioned a lot of genetic disorders. So if you're homozygous for a particular genetic mutation, you're going to develop SMA, or you're going to have Tay-Sachs, or whatever it happens to be, you're going to develop that because it's a sufficient cause. And then everything else will kind of be more of a risk factor, right? So this is being associated with an increased cause of that disease. All right. Okay, so let's say we randomly assign subjects to either 2 years of PA school, being our intervention, and 2 years of graduate school of undeterminate nature. This will be our control. And so then we're going to be testing for the evidence of mental health as an outcome. Okay. These numbers are in the literature. You can find them out there. But of the 100 subjects assigned to each condition, you find evidence of mental health in 12 of the medical school group or PA school group, and 92 in the control group. Okay. Does that sound reasonable for you guys? Evidence of mental health? I don't see a whole lot out there, so just kidding. Just kidding. Okay, so the appropriate measure of association in this study would be looking at incidence density. Don't have any resounding yeses to that. How about power? Nope. How about likelihood ratios? How about an odds ratio? Think no? How about a risk ratio? Okay, it's a risk ratio. Why is there a risk ratio? Okay, so we're looking prospectively, right? So I'm starting, at the beginning of the various schooling and seeing how you guys do as far as mental health goes at the end, right? When could I have done an odds ratio? So what type of, so how would I have had to look at that study in order to get an odds ratio? So I do it retrospectively. So how would I base my patients? How would I categorize them? Yeah, so whether they have evidence of mental health versus not, and then you look to see what their exposure was, or what type of schooling they went to, right? So that would be a way to get like an odds ratio, or risk of having that risk factor of whatever type of schooling they had. Why wouldn't it be power? What is power? Besides what turns on the lights.
Something about the number of people you need to look at.
So it's your ability to detect a difference between groups, right? So again, a lot of it goes back to having your sample size and whatnot, but it's the ability to detect a true difference if one is there, right? So if I don't have enough power, then I might not see any difference between my groups. I'm almost done, okay. And then how about a likelihood ratio? Why wouldn't it be that? What do we use likelihood ratios for? So that's going to be more useful for when you have like tests that you're doing, like diagnostic tests with the sensitivity and specificity. It's trying to tell you that if a patient has a positive test, what is the likelihood they actually have the disease, right? So that's what likelihood ratios are used for. And then when do you use incidence density? So that's going to be for things that happen multiple times in the time period. So the example I always use is like, or that you can use is say you're looking at incidence of influenza. Say you were doing this in children over a say 2-year period, and you look at the incidence in those cases. You could look at children for different periods of time, but it's important that you're doing the actual incidence of the number of cases of influenza you have over the pooled number of time, or how much time you have there. So that's where you see like 12 cases per 100 person months or something like that, wherever it happens to be. And that's going to be your incidence density, right? So those are things that happen multiple times, that can happen multiple times to the same person. Okay. All right. Yep. So the risk ratio would be the answer for that one. All right. We're going to continue on with the review that we didn't finish up in class. So let's say with the next question, you wish to determine the proportion of myocardial infarctions that are fatal within 24 hours of their occurrence. You decide to examine the records of all local EDs and physicians' offices, and you're then going to calculate the proportion of reported MIs that resulted in death 24 hours or less after the patient was initially seen. You briefly discuss your plan with a friendly neighborhood biostatistician who immediately points out that your study is going to be particularly subject to which of the following forms of bias. So either a late look bias, a lead time bias, measurement, observer, or selection bias. So this would be a form of late look bias. Let's find out why that is. So this would be late look bias since it's basically going to be the tendency to detect only cases of a serious disease that were mild enough to be detected before death. So this is that issue where someone had a really massive MI that would result in death before the patient can actually reach the physician's office or emergency department, so they wouldn't be measured. And then consequently, the study might underestimate the probability of early death after infarction. Selection bias is more going to be an issue of you have patients who are not being randomly assigned to different groups, which can introduce bias there. And then observer and measurement bias would be more of the issues of the measurements actually being taken. So less likely to be a problem with something like death, since it's kind of a dichotomous thing. It's pretty easy to determine, but could lead to some issues in other types of studies if you had different outcomes you were looking at. Lead time bias is going to be this detection of a disease by screening earlier in its natural history than it would have otherwise been detected, and so that can actually result in a longer survival time after diagnosis, but actually no change in actual survival time. And then the next question would be the mosquito involved in the transmission of malaria assumes a role of what? So this would be the animal reservoir, the commensal, parasite, surrogate host, or vector. So in this case, it would end up being the vector, because that's what is actually spreading the malaria from person to person. Which of the following would best describe the effect of vaccination against diphtheria when the disease was more common than it is currently? So would we have issues with frequent exposure resulting in boosted immunity after immunization? Would we lose frequent exposure resulting in infection against which the vaccination was not protective? Would we have susceptibility to severe infection redeveloping several years after vaccination? Would vaccination result in hypersensitivity to the infectious agent, or vaccination resulted in unusually severe clinical disease when immunity was not achieved? So the answer here is going to be A, And so this is basically the issue of where patients who were not being re-exposed to the disease later on in life, since it had been pretty close to eliminated, they don't get that natural booster effect. So that's frequently why you're going to see several vaccinations require multiple doses in order to help establish that booster effect to make sure that people retain the immunity over a long period of time. So next, data reported for cases of relatively mild diseases such as chickenpox could generally be characterized as highly accurate because of active surveillance, useful for establishing prevalence but not incidence, valuable for detecting change in the pattern of a disease, valueless because mild diseases are underreported, and then valueless because most patients with mild disease do not present for medical care. In this case, it's going to be C. This would be valuable for detecting the changes in the pattern of a disease. We'll say why that is. So basically we know, especially for more mild conditions, underreporting is going to be very common because again, you get chickenpox, just a normal course of life for some people, and so they're just not going to report that sort of thing. Now, you'll know that what is reported is going to be a certain proportion of the number of cases, and so assuming that stays consistent, assuming that the underreporting stays consistent, if you were to see an increase in the number of reports, say of more severe disease, or just an increase in the number, even though it is inaccurate and not representative of the entire incidence of the disease, it could be reliable. It could be valuable in detecting those changes of pattern over time. It may make you initiate certain changes or maybe more active surveillance. Now in this case, if you're looking for just random reporting, that's not going to be active surveillance. It's going to be more of a form of passive surveillance. Next, we're going to be reporting the deaths for a population of 2,807 men, all aged from 35 to 68. 4 deaths in non-smokers, 11 in men smoking 1/2 pack of cigarettes per day, 18 in men smoking 1/2 per pack. 1/2 to 1 pack per day, and then 43 men smoking more than 1 pack per day. So from this, what could you conclude? Smoking increases mortality. The relationship between mortality rate and smoking is going to be linear. There's a dose-response relationship between smoking and death. To interpret the data, the age of death is required for each case, and then to interpret the data, the information must be expressed as rates for each risk group. So in this case, we're going to be saying to interpret the data, the information must be expressed as rates for each risk group. So essentially what we're seeing here is that the number of deaths associated with cigarette pack smoking at different levels, or cigarette smoking at different levels defined as the packs per day, they can't really be interpreted unless we have some other information about who in the population is smoking. So specifically, if we had a very large percentage of the population was smoking more than a pack of cigarettes per day, you'd expect them to have a comparably large percentage of all the deaths in the group, but we can't really determine that from the information we had. Say if the older cohorts in the population were smoking more heavily than the younger ones, then you would expect there to be a higher percentage of deaths among them due to the age of, the influence of age on mortality. So the raw data in the question implies that smoking would increase mortality, but cannot be interpreted to really show this based on what you have. So if you were to have conversion of the data to rates, that helps to facilitate the interpretation by utilizing the midpoint population in order to help determine those rates. And you can kind of better compare the two groups. So smoking does contribute to overall mortality rates, but cannot be known from the information provided in the question. So, which of the following examples might represent a retrospective cohort study? So say we're looking at cases of lung cancer assessed for prior exposures. We had subjects randomly assigned to active varicella vaccine versus placebo, followed by chickenpox. Subjects with current angina followed for the development of myocardial infarction. Subjects with prior radiation exposure followed for the development of lymphoproliferative cancers. And then subjects with skin cancer assessed for lifelong cumulative sun exposure. In this case, it's going to be subjects with prior radiation exposure followed for the development of lymphoproliferative cancers. So remember that we were looking for a retrospective cohort study, right? So it's going to be something where you're looking at the patients and grouping them based on their exposure to something. So in this case, it would be exposure to prior radiation, and then you're following forward to look for outcomes. So it's a little bit different than what you would see with a case control study where you're basing the patient grouping on outcomes and then looking for risk factors. So this one is potentially a little bit cheaper to do, a little bit easier study to design, but again does not have as much statistical strength as you would see with, say, a prospective cohort study. Next, the Physician's Health Study was a randomized double-blind placebo-controlled trial that was designed to test the effects of aspirin and beta-carotene on cardiovascular disease and cancer. Participants in the trial consisted of approximately 22,000 male physicians who lived in the U.S. and were 40 to 75 years old. Randomization of participants in the study was performed to help achieve which of the following? So elimination of bias, external validity, internal validity, prevention of confounding by known and unknown factors, and then statistical significance. In this case, it would be D. By randomizing, we're helping to prevent confounding by known and unknown factors. So essentially, the goal of the intervention of the trial is to compare these two groups that really are only differing in regards to the intervention of interest. So aspirin, beta-carotene in these cases. You can basically use randomization to make sure that all of the factors that contribute to human variability are going to be kind of equally likely to appear in the control group as it will in the intervention group. So if this is successful, you'll find that the two groups really do not differ significantly from one another, and which can be shown statistically. This will not always be ensured because there's always going to be some things you're maybe not measuring that could have influences, but randomization helps to minimize these confounders. So studies that successfully test its principal hypothesis in an unbiased manner helps to have internal validity, meaning that results are internally consistent and reliable. But you do not necessarily see that all randomized prospective double-blind trials meet this condition. So again, it's going to depend on the type of statistical test that they're doing and all of that. You can always have measurement error, which can affect your results. So even in the best designed study, if you're not measuring things correctly, you can run into issues. So randomization also ensures unbiased distribution of participants to both the control and the intervention groups, but does not ensure that the population represents the general population. So we mentioned that the external validity would be limited here because of the fact that we're looking at older male physicians who may not be all that representative of your general population. So again, a lot of external validity would not be available here. So let's say there's a new virus being reported in the US. It's going to be called Ghana herpessyphilitis, and it's originating from Canada. So it's been reported to have caused 5 deaths so far, and your hospital initiates screening for all patients reporting to the emergency department to see if they have traveled to Canada within the past 6 weeks. So what type of surveillance would this be? So it's not really passive surveillance because you're not relying on people to report these passively. But if you're asking every single patient who's coming into the emergency department if they've been to Canada within that time frame, that would be more of a form of active surveillance because you're actively looking for cases and then reporting those up through the appropriate channels. And what would you call the phenomenon that you see with these first few deaths that represent? So obviously you know that when you had the first few deaths, this is not the only people who have been infected with the virus. It may also not be the only people who've been exposed to it. So this is that idea of the iceberg phenomenon, where you're going to be having a lot more patients who are being potentially exposed to it, a smaller subset of those who are acquire the disease, even smaller ones that get ill, and then these 5 that die. So again, this is just a very small subset of the number of people who could actually be exposed, and which will end up coming out in later time frames once you do the surveillance and find those that are exposed. So what are some potential problems with public health attempts to eradicate diseases? We talked about these previously in the beginning of the epidemiology section, but think about things that, like, for instance, you have when they try to control the fly population in Africa, and they basically were trying to increase the life of the cattle. They were causing basically trying to deal with the sleeping sickness that was from the tsetse fly. They were able to eliminate that, but then all of a sudden they had lots of overgrazing problems, which led to desertification of certain parts of Africa. So that was a big issue. Certainly by doing things like increasing say for instance, or eliminating infant mortality rates or improving that, you run the problem of having overpopulation. So again, having higher populations booming due to decreased infant mortality rates can lead to all sorts of problems like overcrowding, resource constraints, and things like that. So just be aware of the fact that there are ramifications to all these public health initiatives, some of which can be somewhat deleterious. What's the difference between a risk for an outcome and a rate? I've kind of alluded to this previously, but again, risks are going to be using that first initial patient population that's available, that's 100% of the people who are at risk, whereas rates are using that midpoint population. So it's an important thing to remember. And then what are the advantages of a rate? We'll also mention that these are useful for showing that force of mortality. So you can see how the death rates or the outcome rates as they change over time can be affecting your, can affect your rate and give you a better idea of kind of that force of mortality on your samples. And then which of the following would you consider to be a valid rate? So pregnancy in women in the US, testicular cancer in the US population, Republican voting for Floridians less than 45 years old, and then RSV in children less than 1 year of age. So again, here you want to make sure you can identify the population that is accurately representing the people who are at risk for your outcome, right? So for instance, if you're looking at pregnancy in women in the US, that would be false because of the fact that this does not select out for patients who cannot become pregnant, or those that are too young, or those that have had hysterectomies or otherwise sterile. Similarly, you would not want to look at just testicular cancer in the U.S. population because obviously only men would be candidates for developing testicular cancer. The next one would be false as well because if you're looking at all people less than 45 years of age, that would not be valid because that would include people who are less than 18 years old and could not vote in the first place. However, the last one here, this RSV in children less than 1 year of age would be appropriate because, again, all of those children could be potentially susceptible to RSV, and you can look at things like impacts of giving Synagis or palivizumab for prevention of that and the impacts that could have. So here, the last one would be your valid rate. So thank you so much for kind of going through this journey with me, and I hope to take lots from this class and then help to apply it to the next young cohort of PA students. But if you have any questions, please let me know before the test, and I'm glad to talk to you guys. Email me, call me, whatever happens to be. We'll work through any questions you have. Thanks so much. Bye.